Hello, and welcome to the Osteoarthritis Action Alliance Lunch and Learn webinar for June 24th, 2020. Thank you for joining us this month. At this time, I would like to introduce Dr. Garrett Bullock, who will facilitate today's presentation. Dr. Bullock is a Clarendon Scholar at the University of Oxford and is currently reading for a DPhil in Musculoskeletal Sciences, Biomedical Data Science. Dr. Bullock is a physical therapist by training and is a member of the OARSI Sports Exercises Physical Activity Steering Committee, which collaborated on today's webinar. Welcome, Dr. Bullock.
Yes, thank you for having me, and thank you to Dr. Pietrosimone and Dr. Thoma for coming today. We'll get started here in a second. As Katie already said, if you have any questions that you want to ask during the question and answer session, type them in the box and I will say them at the end. I'd like to introduce our two speakers today, both from University of North Carolina. Dr. Brian Pietrosimone is an associate professor in the Department of Exercise and Sports Science and director of the Motion Science Institute at University of North Carolina, Chapel Hill. He holds adjunct appointments in both the departments of orthopedics and allied health sciences in the School of Medicine. His research focuses on comprehensively evaluating the biomechanical and neuromuscular consequences of knee injury and the link between acute injury and the development of post-traumatic OA. Dr. Pietrosimone has published over 150 peer-reviewed scientific papers related to lower extremity joint injury and OA. His work has been funded by the NIH as well as other foundations, including National Athletic Trainers Association, the Orthopedic Section, APTA, and American Orthotic and Protestant. Dr. Louise Thoma is an assistant professor in the Division of Physical Therapy at the University of North Carolina, Chapel Hill. Her research focuses on rehabilitation, physical activity, and physical function in people with arthritis and after joint injury. She's an active member of the APTA, American Association of Rheumatology Professionals, Osteoarthritis Research Society International, and she serves on the Academy of Orthopedic Physical Therapy Research Committee, OARSI Rehabilitation Discussion Group Steering Committee, and on the editorial board of Arthritis Care and Research. And now I'll pass it on over to Dr. Pietrosimone, who will begin the presentation.
All right, thank you very much. We'd like to first thank the OARSI Sports Exercise and Physical Activity Discussion Group, as well as the Osteoarthritis Action Alliance for allowing us to have this discussion today. More specifically, thank you to Aaron, Garrett, and of course Katie for all the work that they put into putting this together. It was very professional and seamless. Thank you. Louise and I are really excited to talk about this topic of loading, following injury, and its link to the development potentially of post-traumatic osteoarthritis. More specifically, some of our data recently has suggested that underloading may be affecting these tissues negatively. And we think that's a bit counterintuitive, right, to how we oftentimes think about mechanics and behavior and how that might actually cause osteoarthritis. So I think it's an interesting discussion today, and hope to have more of it, after these brief presentations. So there's my disclosures. As far as an outline for today, first, I'm just going to briefly introduce the link between ACL injury and post-traumatic osteoarthritis. And then I'll provide some laboratory-based biomechanical evidence for understanding, one, how common underloading is following ACL injury, and then try to establish a link between these underloading mechanical variables and outcomes related to post-traumatic osteoarthritis. And then briefly discuss what might be some of the acute effects of modifying load following ACL injury. Louise is going to talk about behavior-based studies and understanding how behavior might actually affect loading following ACL injury and reconstruction, and try to link some of those behaviors to post-traumatic osteoarthritis development and progression. Then we'll provide a few considerations for future research and then hopefully have a bit of a discussion. So overall, we know that knee osteoarthritis affects millions of people globally each year. And it's been described as the 11th leading cause, just this joint, the 11th leading cause of disability globally. In the United States, we see that 16% of individuals over age 45 have both symptomatic and radiographic osteoarthritis. That the median age of diagnosis is 55 years old, which means that people who have knee osteoarthritis often will have this disability for many years throughout their life. And we know that not all osteoarthritis, right, is created equal, and that there's a lot of work being done to phenotype, different types of osteoarthritis. This will allow us to better understand risk factors for particular individuals, and provide specific types of treatments for those individuals who have differing types of osteoarthritis. Now, we know that one primary risk factor for developing osteoarthritis is the history of a joint injury, and we term this post-traumatic osteoarthritis. We see that between 12 and 35% of all knee osteoarthritis cases occur following an injury. And because these injuries often occur in individuals who are younger and desire more physical activity, right? PTOA has been described as causing more disability oftentimes than individuals who have idiopathic osteoarthritis. There's also reports of worse outcomes following joint replacement for those who have post-traumatic osteoarthritis, compared to those who have idiopathic phenotypes. Now, if we look at the development of osteoarthritis following a specific type of knee injury, an ACL injury, what we see is that individuals often describe persistent symptoms. And this is data from the MOON cohort here in the United States, where we see that even at the 10-year follow-up mark, individuals have remain symptomatic compared to 100% function, which we would see more commonly in uninjured controls. If we look at radiographic evidence of osteoarthritis following ACL injury, regardless of having a reconstruction or not, we see that about a third of individuals develop radiographic PTOA within that first decade. And then by the second decade following reconstruction, we see that it's essentially a coin flip, right? 50% of individuals have radiographic OA. Now, the factors really leading to the development of post-traumatic osteoarthritis have been described as multifaceted. So there's significant evidence to suggest that both, or including structural, biological, and biomechanical factors are associated with the development and progression of this disease. Now, we're going to talk mostly about biomechanical factors today. And if you think about it, this is an interesting group of factors, as it's fairly modifiable by rehabilitation or potentially behavior-related interventions. All right, so mechanics, right, are important because some of these joint tissues are mechanosensitive, and we know that optimal loading is important for optimal health of these joint tissues. And we see, from some really nice animal studies that both excessive loading can cause cartilage damage, right? And insufficient loading can cause cartilage damage. So you really have like this, Goldilocks type of hypothesis where too much or too little can cause similar changes, deleterious changes to this joint tissue. Now, if we look at human studies and we look at pathic knee osteoarthritis, we see that higher loading is usually linked to progressive changes in the joint. All right, and these studies have mostly looked at later stage individuals that have developed idiopathic OA. What we are concerned about is what are the early changes that may happen following injury that may progress someone to post-traumatic osteoarthritis. And there's less in the literature to really understand if they're similar to those of idiopathic OA. So what we'd like to talk about today is a little bit of, one, how do gait biomechanics change following ACL injury, and then how do they associate with some of these changes in PTOA-related outcomes. So first, how do these gait biomechanics change following ACL injury and reconstruction? So with a group of individuals in the Thurston Arthritis Research Center here at UNC in the Department of Orthopedics and us. We kind of put together a comprehensive longitudinal cohort to evaluate some of these changes in biomechanics and biology and structure following ACL reconstruction. And this is one of the first papers where we actually use a longitudinal design to look at ACL reconstructed individuals at 6 and 12 months following injury and reconstruction. And then we got a group of age, sex, BMI matched controls where we evaluated their gait biomechanics at a single time point. And we evaluated gait biomechanics during self-selected gait speed using overground force plates and three-dimensional motion capture. Now, our first look at this, we wanted to evaluate vertical ground reaction force to each of the extremities at 6 and 12 months following ACL reconstruction. You can see that this is a look at vertical ground reaction force through the entire stance phase. And this variable kind of gives us an idea of the total vertical force imposed on the extremity when the foot is in contact with the ground. So you can see here at the beginning, we have a dramatic increase in the force, as the foot comes in contact with the ground. And then it decreases over mid-stance and then increases again as the individual toes off. So at 6 months, we see that the involved limb, the ACL reconstructed limb, actually had a decrease, significant decrease in force compared to the contralateral limb at that initial peak, right? As well as that second peak, during toe off. At 12 months, we saw that they were actually symmetrical. So they were underloading at 6 months compared to the contralateral limb, but we found them to be symmetrical at 12 months. But at second look, when we actually compared both limbs to a control group, what we saw is that at 6 months, we had that dramatic underloading, at both 6 and 12 months compared to uninjured controls. And when we looked at the contralateral limb, we saw that the contralateral limb was indeed underloading compared to the uninjured controls at both 6 and then even more so at 12 months, suggesting that this symmetry that we saw between limbs was actually the uninjured limb coming to meet or underload similarly to that reconstructed limb compared to controls. We looked at other mechanics such as knee flexion angle throughout stance and saw similar findings where the ACL reconstructed limb was more stiff, both less flexion and less extension at 6 months. Extension regained, but they had less flexion at 12 months compared to uninjured controls. And we saw that the contralateral limb was also less flexed throughout the entire stance phase compared to uninjured controls, suggesting that this uninjured side was also coming to meet that injured side. We found the same thing with knee extension moment, where sagittal knee moment was loaded compared to the contralateral limb in both in the ACL group, but also the contralateral limb was different from controls at 12 months. Again, suggesting this lesser loading in both limbs compared to uninjured controls. Now, how do you bilaterally underload? Well, we saw that some of this has to do with the fact that individuals begin to walk slower at that 12-month time point. So there was a portion of the variance associated with this change in mechanics that could be explained by that change in just slowing down or having a slower gait speed. But what we do see is that there's still 2/3 to almost 90% of the variance that is unexplained by just a change in walking speed. That may be explained by changes in mechanics or neuromuscular control bilaterally in these individuals. So in summary, we see that ACL gait demonstrates underloading early, lesser peak vertical ground reaction forces, stiffer knees throughout stance, and less knee extension moment. And this symmetry may be actually bloating, which could be explained by a change in walking speed, but also some of these neuromuscular compensations. So how do these gait biomechanics associate with joint tissue biology and patient-reported outcomes? So we conducted a series of experiments to kind of look at the association between gait biomechanics and biology. And in our first one, we used a cross-sectional study. These were a variety of months post-ACL reconstruction. And we basically took some resting blood draws and then had individuals, perform gait biomechanics in our 3D motion capture system. What we saw in this initial study was that our peak vertical ground reaction force was associated with type 2 collagen turnover, but we saw that lesser peak vertical ground reaction force was associated with more collagen breakdown relative to synthesis, suggesting that the individuals who were underloading were also going through more type 2 collagen breakdown compared to those individuals who had higher vertical ground reaction forces relative to their body weight. We thought, well, maybe this is just a factor of time post-injury. So we looked at an earlier group of individuals. This one had a little bit more tighter control over. These individuals were 6 months post-ACL reconstruction, and they all had a similar graft type. We used all patellar tendon autographs. We looked at two different types of biochemical markers, IL-6 and MMP3, which are pro-inflammatory cytokine and an enzyme involved in cartilage matrix degeneration, respectively. We also evaluated some different biomechanical outcomes, the first here being the rate of loading. And we saw something very similar, that individuals with lesser loading rates actually had increased MMP3 compared to those with higher loading rates at 6 months. And we looked at the knee adduction moment, which may be a better marker of medial compartment loading at the knee. And what we saw was something very similar. Higher MMPs were associated with those who had lesser adduction moments. And again, individuals with lesser adduction moments had less inflammation compared to those with higher moments at 6 months post-ACL reconstruction. We also performed a cartilage stress test where we had individuals come in. We took a resting measure of COMP, or cartilage oligomeric matrix protein. We had them walk for 20 minutes, and we took another test of their serum COMP. What we saw is that individuals who had lesser peak loading and lesser loading rates over that 20 minutes also had greater COMP changes, following a 20 minutes of walking. At 6 months, we also saw that lesser loading was associated not just with changes in biochemistry, but also changes in T1 row relaxation times on MRI, which are associated with compositional change in the cartilage. So actually diminished proteoglycan density within the cartilage, which is associated with it as an early marker of PTOA. What we saw here were lesser peak vertical ground reaction forces, lesser loading rates, and lesser knee adduction moment at that 6 month time point was associated with these deleterious changes in cartilage composition. And finally, we evaluated patient-reported outcomes at 6 months and 12 months, and we saw that our individuals who loaded less at the 6 month time point had worse patient-reported outcomes using the KOOS at 12 months. Suggesting that this is not just related to these disease-related changes, but potentially also symptoms. Now, I think it would be very easy to say that, lesser loading is definitely always associated with worse, cartilage outcomes, but there is a bit of contradictory evidence within the literature from different groups. And I used worse here as basically, to suggest more deleterious changes. But what we see is that other groups, Liz Wellstand and the Delaware group at the time, they found evidence that's similar to what we have just presented, that at 6 months, medial compartment contact forces, those who had less lesser medial compartment contact forces had more likely to have knee OA at the 5-year follow-up. But there's other groups that have taken types of MRI outcomes looking at composition that have showed that greater loading may actually be worse for time points post-ACL. So here's some evidence, from one of our studies last year where I think that we can see that time post-injury may cause a problem in us understanding greater versus lesser loading. So we divided individuals up into asymptomatic or symptomatic based on their Q scores. We saw that individuals less than 12 months post-ACL reconstruction who were symptomatic at that time actually showed lesser loading compared to our asymptomatic ACL reconstructed individuals. At 24 months, that relationship was different. Individuals who were symptomatic at that point actually showed greater loading with that vertical ground reaction force compared to those asymptomatic controls. So this might suggest that there is a complex relationship and time might be a factor that modifies this. But what is interesting is that if we looked at our symptomatic group at these different time points, we saw that, there were time points where they were greater loading and there were time points where they were lesser loading. Our asymptomatic individuals after ACL reconstruction all had very similar biomechanical loading profiles. You can see that asymptomatic groups, regardless at what time point they were post-injury, are almost right on top of each other, suggesting this might be a template that we can use for, guiding rehabilitation in this group of people. So again, in summary, lesser loading may be associated with these serum and synovial fluid biomarkers, compositional MRI changes, and worse patient-reported outcomes. But time post-ACL reconstruction may influence. So how can we modify? What happens when we modify some of these mechanics? Here are some early studies where we've been looking at actually to develop more of a mechanistic approach in evaluating the association between mechanics and biology. In this approach, what we use is real-time gait biofeedback. We actually cue changes on that first peak of the vertical ground reaction force. And we can teach individuals to increase their loads, decrease their loads, make their loads symmetric, and evaluate the changes that they have in both biochemical changes as well as structural changes as well as biomechanical changes. Some of our early data suggests that if we teach individuals to increase loads by just 5% of their vertical ground reaction force, that we can create more normal biomechanical profiles. So here you can see that the solid line is the high loading condition, which is 5% greater body weight. And you have a more dynamic vertical ground reaction force waveform than their normal walking at 6 months post-ACL. And here you can see by lowering it, we actually have a flatter curve, a less dynamic waveform. The knee flexion angle actually responds where we have an increase in knee flexion angle when we increase their load. And we see an increased knee flexion angle throughout stance by decreasing their load, but you can see that they take this very crouched gait. They actually have a stiffer, less dynamic knee flexion angle throughout stance. And you can see if you're used to looking at Gait, here's an individual who is increasing their load 5%, and you have a more flexed and then extended knee through mid stance. And then here you have a more crouching type of gait where this individual is actually more flexed throughout stance phase, but kind of stiffening that knee joint. What we see is that in individuals who actually have an increase in comp over a 20-minute period normally in their control condition, if we overload them, there actually is a significant decrease in their serum comp levels. So this suggests that potentially changing load, modifying load may also modify acutely some of those biochemical changes. So overall, increasing load may normalize gait mechanics, and there is some research to suggest that modifying load may impact some of these joint tissue biology. Right, so I'm going to switch this over to Louise.
Okay. Okay, and can you see my slide?
Yes.
Great. So thanks, Brian, for getting us started. Now I'm going to talk about the behavioral contributions. And these are, this is my disclosure from my postdoc. So we're going to take a look at this from a different angle. While biomechanics provides some insight about what's occurring with each step at the joint level, we can examine the behavioral contributions to underloading that occur at the person level. That is what they're doing over their days, months, and years, and how that might affect loading. So we'll try to specifically address two questions today. How does behavior affect load after ACL reconstruction? And are these behaviors related to post-traumatic OA development? One of the most prominent behaviors after ACL reconstruction is sport or return to sport. And this is almost always a goal of postoperative rehabilitation, since 94% of patients expect to return to sport after ACL reconstruction. And with a successful return to sport, this would likely mean a return to high loading activities like running, jumping, and cutting, which are 2 to 3 times more body weight on the knee than walking. In addition, the combination of adding practice and games likely means a higher volume of activity and overall loading. However, we know that many fail to achieve or sustain this milestone of return to sport. In a now eminent systematic review by Dr. Claire Ardern and her colleagues reported that, only 55% return to competitive sport and only 81% return to any level of sport. So then, is return to sport or failure to return to sport associated with the development of post-traumatic OA? Oisted and Meyer-Risberg and colleagues shed light on this question in a secondary analysis of data from a prospective cohort in Norway of 258 adults after ACL injury and reconstruction. And they observed that participants who returned to pivoting sports like soccer, handball, and basketball had lower odds of symptomatic and radiographic knee OA at the 15-year follow-up. Now, this analysis provides some preliminary evidence that underloading, which defined here as a failure to return to sport, may play a role in post-traumatic OA. However, there are limitations of this study. For example, other factors like reduced knee function, could explain both the failure to return to sport and increased OA. But even beyond those specific limitations of the prior study, looking at behavior from the perspective of return to sport is very limiting. From a measurement perspective, sport is often recorded as a categorical or dichotomous variable and measured at only one time point. And this only offers a cursory look at how behavior can affect load. Other common historical measures like the Tegner Activity Scale or the Marks Activity Score offer a little bit more information about the type of activity or the number of times per week for participation, but this really lacks the granularity and detail needed to understand load and the effects of behavior on load. Another limitation of looking at return to sport is that there are other confounding variables as this decision is multifactorial. So some of those other variables may or may not be modifiable and may or may not be related to knee function. If we want to examine the most common behavior that loads a knee, it's walking. As depicted here in this classic figure by Andriacchi, healthy knee cartilage homeostasis requires cyclic loading to maintain healthy structure and biology. And this is primarily accomplished by daily walking. And as Dr. Pietrosimone alluded to earlier, walking from the biomechanical perspective shows that there's differences in loading magnitude during that single step after ACL reconstruction, which contributes to worse cartilage health. But when considering this model from a behavioral perspective, we can think about the volume and frequency of cyclic loading from walking as number of steps per day. The advances in accelerometry over the last 15 years have really greatly improved our ability to quantify this physical activity in the real world. And while there are still many limitations, these tools are really good at quantifying walking behavior specifically as steps per day or moderate to vigorous physical activity, which is an important level of activity for overall health. So how is walking and physical activity behavior affected after ACL injury and reconstruction? A group led by Dr. David Bell and Chris Kunze were among the first to tackle this question. In their first study, they examined walking and physical activity in a matched cohort of college-age students with and without a history of ACL reconstruction. The samples were matched on age, sex, and activity level using the Tegner Activity Scale. And despite no differences in patient-reported measures, which were the Marks Activity Score and the Tegner Activity Scale, participants in this study with a history of ACL reconstruction walked about 1,600 fewer steps per day and spent about 15 minutes less in MVPA compared to their healthy counterparts. And at first glance, this may not seem like a lot, but to think about this over the course of a week, it adds up to about 11,000 less steps in a week and nearly 2 hours less in moderate to vigorous physical activity. So the individuals with a history of ACL reconstruction are losing a day's worth of cyclic loading compared to their healthy counterparts. In a subsequent analysis, they also found that MVPA was not related to knee function or quadricep strength, and that a lower proportion of people after ACL reconstruction meet national physical activity guidelines compared to healthy controls. So then, are these walking and physical activity behaviors related to post-traumatic OA development? This is really an emerging area, and so we just have some early evidence that this may be the case. Dr. Hope Davis Wilson worked with Brian and recently graduated here from UNC and had an abstract accepted to the American College of Sports Medicine annual meeting and examined the association of walking behavior quantified as steps per day with cartilage breakdown. And the cartilage breakdown was quantified using that stress test that Dr. Pietrosimone described earlier. And so what we observed here was that fewer steps per day was associated with a greater change in comp or greater cartilage breakdown after this treadmill stress test. And this initial study suggests that those who accumulate less steps per day or less cyclic loads may result in less resilient cartilage to this load challenge. And this was a focus of Dr. Davis Wilson's dissertation, and so look for more to come from this in the coming years. So as Dr. Pietrosimone also highlighted earlier, there is this balance between underloading and overloading. And overloading has been a prominent mechanism to contribute to the development and progression of OA. In fact, overweight and obesity, which is common after ACL reconstruction and ACL injury, is the leading risk factor for OA along with that prior history of injury. And then there's other risk factors like occupations with heavy labor and repetitive motions. These are all thought to contribute in part to osteoarthritis through overloading. But the contribution of joint loading to this development is likely not overloading versus underloading, but rather a combination of overloading and underloading. Here, we recently published an analysis of the multi-center osteoarthritis study, which is a cohort of older adults with or at risk for knee osteoarthritis. And this analysis was led by Dana Vonier at the University of Delaware. And in this analysis, we are investigating the idea of cumulative load. And here we conceptualize cumulative load as the combination of BMI and steps per day, and how this related to worsening cartilage damage as quantified by MRI over the next 2 years. And I'm just going to highlight some of the results here. Here within the lowest tertile of BMI, those with the lowest number of steps per day had higher risk of worsening cartilage damage over the next 2 years compared to those with the highest steps per day. So this provides some evidence for underloading as the mechanism for OA progression. And then here on the right, among those in the middle and highest tertile of steps per day, so among the more active people, those with high BMI had higher risk of worsening cartilage damage over the next 2 years compared to those with low BMI. And this supports overloading as a mechanism for cartilage damage. So if we think specifically about the context of post-traumatic osteoarthritis, the evidence we presented today of altered biomechanics, slower gait speed, less walking, and less sport and physical activity after ACL reconstruction may result in less load magnitude and less loading cycles, which in this model contributes to deconditioned cartilage. Then this deconditioned cartilage will have less resilience and is potentially more susceptible to damage from acute bouts of overloading, which may come from premature return to sport, sporadic sport participation, and particularly when individuals are overweight or obese, which is common after ACL reconstruction. And in fact, there are some recent studies that support this premise. Culviner and colleagues in 2018 observed that athletes who returned to sport before 10 months had greater odds of bone marrow lesions at 1 year compared to those who returned to sport after 10 months. And Van Ginkel in 2013 observed that knee cartilage was slower to recover after a 30-minute run in athletes who returned to sport at 4 months compared to those who returned to sport at 6 months. So to summarize this evidence, behavior may affect load after ACL reconstruction due to low rates of return to sport and less walking and physical activity. And these behaviors may relate to PTOA development and progression because the lower loading in preliminary evidence is associated with worse cartilage health. But I do want to acknowledge that much of this evidence presented here, especially with regard to the behavioral evidence, is preliminary still. Most of the studies in this area are cross-sectional with small sample sizes and limited variability within the samples. However, I hope we've convinced you today that there is a compelling body of evidence to support the need for larger longitudinal trials to fully characterize the role and the balance between underloading and overloading in the development and progression of post-traumatic osteoarthritis. And I know there are several research groups, ourselves included, actively gathering evidence, and so I'm confident that we're really going to be learning much more in the coming years. So those are some references. And then, so thank you. We'd love to thank the Osteoarthritis Action Alliance, OARSI, and the SEPA group specifically, and the Athletic Trainers Osteoarthritis Consortium for joining us today, and we'd be happy to take any questions at this time. I know we're maybe a little bit over here.
Yeah, thank you, Brian and Louise, for presenting today. I thought that was some really interesting information. I had a question for each of you. For Brian, I thought it was very interesting about the creating the feedback interventions real time with the ambulation on the treadmill. I wanted to have a little bit more information on that. Specifically, how many times was this done with these patients? Was this a one-time event, or going forward, have you thought about how many times does it take to, have you seen to affect gait from a long-term stance, and about educating and providing specific interventions for these patients as they go in between sessions, as say they're in a physical therapy clinic?
Yes, projects were really kind of experimental in nature, just to see that if we change the mechanics or we change the loading or ask people to change, cue them to change their loading, what would happen to other biomechanical variables throughout stance, as well as to see what would happen to acute changes in both biochemistry and, we also are evaluating like ultrasound images of cartilage deformation. So these were just, one time. Individuals came in 4 separate times in different conditions to see, what would happen in overloading versus underloading versus symmetrical changes. Really kind of to link the change in load to these links, to these changes in mechanics and biology. The next phase, Garrett, is really to determine if we can cause, lasting changes in gait, and then to determine, how that might change some of those measures of cartilage and patient-reported outcomes, moving forward. So we're working on that right now.
Sounds great.
Oh,
and for Louise, I thought it was very interesting you describing the chronic overloading with acute bouts of overloading causing increased cartilage damage. From a physical therapist standpoint, how do you go about educating your patients? And this could be from total knee people that are candidates for total knee replacement all the way up to elite soccer or other court sports. How do you educate them on their day-to-day and behavioral actions with trying to decrease their underloading and mitigate their acute overloading responses?
Yeah, I think that's a great question, Garrett. Thank you. I think that one thing we can think about is that to date and historically, rehabilitation after knee injury has really focused on the goal of return to sport. And when we focus solely on that goal of return to sport, we're likely not having the discussion about what does healthy loading and activity mean for the joint moving forward. And then it could also set you up for, the patient is often discharged maybe before they return to sport or right as they're returning to sport. And then if they don't return, or if they return and then stop participation soon after, we really might have missed our opportunity to educate them on how regular physical activity and consistent exercise is beneficial for that joint. So I think this is really an opportunity to identify how can we better promote physical activity and healthy physical activity in rehabilitation while we have them there as a captive audience. And some of the work that I was a part of at the University of Delaware was looking at how we can even simply add a Fitbit during rehabilitation after total knee replacement, and just giving weekly step goals as part of rehabilitation, and how we can, that even just small dose of a physical activity intervention can increase physical activity at discharge and up to 1 year later.
Yeah, that's a great intervention that I've seen with from different clinics and different perspectives. A follow-up on that is, so this is probably more complex and more time than we have discussed about this, is trying to find that Goldilocks amount of loading for different occupations in sport. Now, some sport I would argue would probably be detrimental to joint health in general, from a long-term perspective compared to general population. But how do you think we go about finding this optimal loading strategy from an injury or non-injury standpoint going forward from the light of this research you presented today?
Yeah, that's a great question. I think that I think shifting our perspective and including, how underloading is involved will be important as we set up our investigations in the future. Because like Brian mentioned in his presentation, it might not just be, the loading at that point, but where they are in their recovery. Is it 6 months? Is it 2 years? Because there could be differential effects there. The other thing that I think about a bit is that indeed we know that, elite, for example, elite ultra running is related to some osteoarthritis, but that the development of osteoarthritis, but that recreational running is not and is healthy. And currently our epidemic in the world is physical inactivity, not too much loading. And so I think that as we think about how to educate our patients and the general public, we don't want to put too much emphasis on the concept of overloading, because it's overall a larger problem that we're likely underloading and not getting enough activity.
Great. I haven't seen any other questions from the group, so I think I'm going to turn it back over to Katie now, because she wanted to have some final thoughts before we end today.
That was great. Thanks to all of you for the presentation, and to Dr. Bullock for your partnership in helping get this presentation set up. I am going to put out a quick poll, so before you leave, if you could quickly answer the poll. And then I wanted to put in a plug for next month's Lunch and Learn presentation. That's going to be on July 15th, and we will have Dr. Amanda Nelson presenting an overview of the American College of Rheumatology guidelines for osteoarthritis management. So we hope that you can join us. I will include a link to the registration for that in the follow-up email from today's session. And really grateful to you all for tuning in, and hope you have a wonderful day. And thanks again to our presenters.